Yeah.
Like we're nearing 100 participants, so we'll give folks
Great.
just a minute to join and we'll get started. Like our attendees are sort of leveling out. Make sure our session is recording, and then Brock, if you want to get us started.
Okay.
Go ahead.
Good afternoon, everyone. I'm Brock Slaybaugh, Chief Operations Officer for the National Rural Health Association. I'm talking to you on the road somewhere between Leawood, Kansas and Wichita. So unfortunately, my travel schedule got a little bit upended today. But nevertheless, I am most excited to be able to help coordinate today's program on improving pediatric emergency care in rural America nationwide. And so this has been a long time work of folks at the University of Texas, represented by Kate Remick, who's on the line this afternoon, as well as NRHA and many of the other participants in this longstanding work of trying to do what we can to improve pediatric care in emergency rooms in rural America. I am looking forward to this program today, and I hope that all of you take opportunity to listen to the resources that are available through this programming. And we would like to see every rural hospital in the country be able to participate in this program at some point. So with that, I'm going to turn it over to Casey Patika and let them get the program started.
Thank you so much, Brock, for helping coordinate today's session, and we appreciate your support. Again, good afternoon, everyone. My name is Casey. I am a program coordinator for the EMSC Innovation and Improvement Center, and today I'm joined by my colleagues, Dr. Kate Remick and Lisa Hinosa. And I will have them introduce themselves here in a bit, but we are also excited to have with us a special guest who we'll get to hear from later in our presentation. We look forward to sharing with you a bit about how participation in a quality improvement collaborative can help your emergency department improve your pediatric readiness. Before we get started with today's session, we would like to acknowledge that the Emergency Medical Services for Children of EMSC Innovation and Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. Additionally, NPRQI is also supported by the Toyota Way Forward Fund, and the contents of today's presentation are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. So I'm going to get us started today by walking through why pediatric readiness and pediatric quality improvement is important for pediatric patients. So here's a surprising fact. 85% of children who need emergency care are treated in general emergency departments, not in pediatric-specific facilities. That means most kids who come in with serious injuries or illness are seen in hospitals that primarily serve adults. So what does that mean? It means general EDs need to be prepared to care for children effectively. Here's the challenge. Many emergency departments see very few pediatric patients. When pediatric patient volumes are low, it's harder to prioritize pediatric-specific training, equipment, and systems. As staff may not encounter pediatric cases often enough to maintain confidence and skills. This creates a gap because when a critically ill child does arrive, the team needs to be ready. Improving pediatric readiness relies on understanding current gaps. This is where quality improvement comes in. Pediatric readiness means having the people, processes, and resources in place to provide high-quality care. The goal is simple. Every child should receive safe, timely, and effective care no matter where they show up. You may have heard the phrase, you can't improve what you don't measure. That's why quality improvement, or QI, is so important. It's a systematic, continuous actions that measurably improve care. Quality improvement is not a one-time effort. It's ongoing. It focuses on identifying gaps, measuring performance, and implementing changes that lead to better outcomes. QI has been identified as one of the leading drivers of pediatric readiness, along with the presence of pediatric emergency care coordinators, or PECs. When emergency departments engage in QI, they see better clinical care and improved outcomes for children. Here's why this matters. Again, 85% of children are seen in EDs that don't specialize in pediatric care across the U.S. When those EDs have high pediatric readiness, there's a possible 76% potential reduction in mortality risk among ill and injured children. This is a huge impact, and it shows why QI is essential. So improving pediatric readiness through quality improvement isn't just about compliance, it's about saving lives. The National Pediatric Readiness Project, or the NPRP, empowers emergency departments to improve their capability to provide high-quality care for children, also known as being pediatric ready. This is led by the Health Resources and Services Administration, EMSC program, with support from multidisciplinary organizations. The NPRP offers free and open access assessment opportunities as well as resources to address gaps. Quality improvement is a key driver in pediatric readiness. Facilities that incorporate specific pediatric quality improvement initiatives demonstrate an average increase of 26 points on their 100-point scale of pediatric readiness. Hospitals that improve their pediatric readiness see significant benefits. For example, there's a 76% lower mortality risk in children, and an estimated 2,143 children's lives could be saved across the U.S. every year. These numbers show how critical readiness is. Now that we've talked about why pediatric readiness matters, let's look at how we can actually improve it. This pathway shows the steps emergency departments can take to strengthen readiness using the national assessment data and improvement efforts. The first step is to prepare. Get your ED leadership involved and review the checklist and toolkit provided by the NPRP. Then you're ready to take the assessment. This is a tool to assess your ED's pediatric capabilities and identify gaps. You can complete the open assessment today and see your ED's pediatric readiness score, and this will also help you prepare for the 2026 National Assessment Period. Then we review progress. Look at your scores, benchmark against national standards, and identify areas for improvement. After reviewing, we move to improvement. This is where EDs implement changes, whether that's adding pediatric champions, refining processes, or using quality improvement strategies. Once improvements are in place, EDs can get recognized for their efforts. State-run pediatric readiness recognition programs help highlight commitment to pediatric care and encourage continued progress. And finally, we encourage EDs to keep it up. Pediatric readiness isn't a one-time project. It's an ongoing process with regular reassessment and continuous improvements. With that, I'm going to hand things over to Dr. Kate Remick.
Thanks so much, Casey, and good afternoon, everyone. It's really nice to see so many folks on. My name's Kate Remick. I'm a pediatric emergency medicine as well as EMS physician based at the University of Texas, as Brock said. I also am co-director of the National EMS for Children Innovation Improvement Center and executive director for the National Peds Ready Quality Initiative, and just really excited to share a little more about this work today. You know, healthcare systems have embraced quality improvement for a long time. Many of you may find yourselves in centers that are also doubling as stroke centers, STEMI centers, sometimes as trauma centers. And in all of those specialty center types, quality improvement is foundational. But when it comes to the care of children, we faced a number of barriers. And the biggest barrier is that which Casey alluded to earlier on, which is that while most children are seen in general EDs, the great majority of these EDs take care of fewer than 10 children per day. And that means that we have limited exposure to what we would normally choose for quality improvement efforts, which is high risk, low frequency conditions. Historically, folks have focused on conditions like sepsis or, in the case of stroke, STEMI, and trauma centers, strokes, heart attacks, and severe multisystem trauma. But we know that if the great majority of children are going to EDs of this nature, and if we're not focused on how care is being provided to children, then we may really fumble when it comes to a critically ill or injured child for whom we haven't optimized our processes. Because of that, we often have limited exposure to these children, which leads to limited opportunities to enhance our resources for them, and also to really hone our skills related to either pediatric care or quality improvement. In many EDs, we find that there are competing priorities as well. And so our goal is really to make this as easy as possible for emergency departments of all types, all different resources to be able to engage in this work. And ultimately, our goal is to really establish continuous quality improvement efforts that are sustainable and do not require a significant amount of time or effort or training in order to participate. So we'll be sharing a little bit more about how we're going to go about that over the next, hopefully 25, 30 minutes or so. And I'm going to pass it to Lisa, who's going to talk a little bit about what is the National Pediatric Readiness Quality Initiative.
Thank you, Kate. My name is Lisa NRHA. I'm the Senior Program Coordinator for NPRQI. It is so great to see so many new names on the webinar. I love that folks are really getting interested in NPRQI and quality improvement and pediatric readiness. So for those of you all that are new to NPRQI, I did want to share some information about how NPRQI supports pediatric readiness. The National Pediatric Readiness Quality Initiative is a free, self-paced quality improvement data platform that is specifically designed for emergency departments. And what it does is that it helps EDs to measure, benchmark, and improve their performance on the most key pediatric processes in a very secure way. One of the biggest benefits of NPRQI is that it gives hospitals a clear framework for continuous quality improvement, which is really essential for improving pediatric readiness and making sure that kids get the best care possible. And here is why this tool is so important for quality improvement, is that it really helps EDs to track their progress while they're actually implementing their quality improvement projects. Without NPRQI, it can be hard to know if what you're doing is actually making a difference and even moving the needle toward pediatric readiness. So ultimately, NPRQI is really designed to inform and empower frontline staff at emergency departments so that they can really gain the insights and have access to the tools that they need to make real improvements. This visual is an implementation flow of NPRQI for a path to better pediatric care through NPRQI. It starts with accessing the free, secure, web-based platform. From there, you're able to capture pediatric patient encounter. Once you have entered your data, you're able to get that data visualized in the form of a dashboard. So you can use that information to measure and assess your pediatric emergency care performance. You can benchmark your performance against the national performance as well as other similar pediatric patient volume sites as yourself. You can then use that information to really find an area to focus on in terms of implementation of quality improvement strategies, start implementing those strategies, and again, reflecting on that dashboard to see if what you're doing is really working and if it's aligning with high pediatric readiness strategies. And then ultimately, being able to improve and drive high pediatric readiness results. I'm going to hand it back to Kate.
So, as you've been hearing, we're throwing out this term quality improvement, and I just want to reiterate again what Casey mentioned early on, which is that those emergency departments that engage in quality improvement have an average adjusted increase in their pediatric readiness score by as much as 25 points plus. So this is a huge opportunity to really transform outcomes for children. But what I also want to state is that some people feel like this idea of quality improvement is a huge hurdle or it's maybe too complex or difficult to implement. And NPRQI really was developed to support frontline healthcare teams. It's not built only for any particular type of clinician or nurse. It's built for all nurses, all clinicians, all frontline multidisciplinary teams. And the beauty of it is that you can engage with quality improvement, but don't have to have any quality improvement training or certifications in order to do it. It's really intended to be very interactive and user-centric so that it guides you through the entire process. In addition, it's completely free, thanks to our funders. There is no financial resource requirements, no investment that's needed from your institution in order to engage. And it's really focused to help support that multidisciplinary collaboration. Next slide, please. So we built the National Peds Ready Quality Initiative around the most common reasons why children come into the emergency department. And this was necessary because we wanted to make it relevant and meaningful for emergency departments that don't see hundreds of thousands of children in a given year. But these are the reasons why children come to the ED every day, including those that are right down the street, those that they view as their community hospital. And they come in because of, basic illness requiring assessment. They come in for acute head trauma or an acute seizure. Sometimes it's related to respiratory distress or a mental health emergency. Vomiting and dehydration is extremely common. And then lastly, in some children, they are critically ill or injured and they do require transfer to an alternate facility. But the goal of the National Peds Ready Quality Initiative is to optimize the foundational processes of care that are common to a variety of ultimate diagnoses, but are based and grounded in the initial presentation or initial complaint that a child has when presenting to the emergency department. Next slide, please. So as you engage with the National Peds Ready Quality Initiative, what you'll be able to see is how you're performing relative to your entire pediatric population. You'll be able to see how your ED is performing with the assessment and triage of a pediatric patient, including screening for things like suicide risk. In addition, you'll be able to look at how well you're doing with diagnostics and interventions that are grounded in evidence-based practices, and ultimately how that leads to the appropriate disposition of those patients. So it follows the entire patient encounter from entry in the emergency department until they're ultimately discharged, either through transfer, admission, or truly discharged to home. Next slide, please. So I wanted to walk through a potential case, and this is a case of a hospital called Rite Aid Hospital. And they see approximately 2,500 pediatric patients per year. This is considered a low medium volume category. Our low pediatric patient volumes are those under 1,800, but this is very much a standard pediatric population that many emergency departments see. And they really want to focus on improving pediatric readiness, which hopefully is why we're all here. We're all trying to improve outcomes for the pediatric population. And in this case, they don't unfortunately have a dedicated pediatric champion, or what we often refer to as a pediatric emergency care coordinator. And they don't necessarily have any prior experience with pediatric quality improvement efforts. There's no kind of background or training. But they decide to go ahead and engage with NPRQI as part of this larger process. And for them, they decide, well, let's go ahead and start entering some of our pediatric patient data to find out how we're performing when it comes to the care of the pediatric patient and figure out if this might be an opportunity for us to improve our pediatric readiness. So next slide, please. So as this hospital gets involved in pediatric readiness, what they would do is they would go in and look at charts that they had, patients that they had seen in their emergency department over the prior, let's say, 4 months, in order to achieve a certain number of patients, in this case, maybe 20 to 30 patients that they wanted to look at. And they would enter those records into the system, and then they would be able to see how they're performing when it comes to the care of the pediatric patient. And if you could click through to the next animation, what you'll see here is that they decided that they wanted to focus perhaps on pediatric pain assessment. So what's displayed here on this table is a sample site dashboard that any site who's participating in NPRQI would see. This is a dashboard of what we call our core set of measures. They're not specific to a particular chief complaint, but really are relevant to any pediatric patient who presented to the emergency department. So they include things like weighing children in kilos and assessing pain. They also include things like reevaluating vital signs in those patients that are of high acuity. As an example here, in this case, ESI triage levels 1, 2, or 3. In addition, it looks at patients who are transferred out. But what this site, Rite Aid, noticed is that when they went to their initial dashboard and looked at the performance of patients who they had entered into the system, is they noticed that their performance when it came to pediatric pain assessment was pretty low at 54% compared to the national cohort, which in this case is performing at 79.3% of pediatric patients that are having pain assessed. You'll also notice that in addition to being able to compare their individual performance to national performance, they can also compare their performance to a cohort, and that cohort is other hospitals that are similar to them. So other hospitals that fall in that medium volume category that likely have similar resources to those resources that they have. And they found that even in comparison to the cohort, that their performance when it came to pain assessment was below where they'd like to be in terms of overall benchmarking. And so this was an opportunity for them to say, we'd really like to focus on pediatric pain assessment and see how we can make improvements based on this initial baseline data. Next slide, please. So as they're thinking about, gosh, why is our performance of pain assessment in the pediatric population so low? We're only at about 54% of our entire pediatric population that's having pain assessed. There might be a few opportunities that we have to make improvements. And these might be some of the strategies that an emergency department, or in this case, Rite Aid Hospital, chose to undertake. First is perhaps training staff on how to assess pain during triage. How do we make sure that they feel comfortable with a variety of pain scales, whether it's a FLAC scale or a FACES scale or a standard, 1 to 10 pain scale. In addition, they might have noticed that their policies and procedures did not have validated pain scales in place. And so how can we go about adopting new policies that integrate those pain scales for the specific age groups that are needed in order to assess their pain? And lastly, might we be able to optimize our electronic medical record to provide some alerts to notify the care team that we need to document pain yet again prior to discharge so that we know that pain is being assessed and reassessed in this population? And so the question is, if we were to go about implementing these changes, how do we know if these changes are actually making a difference in the outcome of our particular patient population? So next slide, please. So the nice thing about the NPRQI is it allows us to track patient encounters over time and keep up to date with actual performance. And for a given site, that might be on a weekly basis or a monthly basis or a quarterly basis, and it really depends on your pediatric patient volume and how you plan to address that population. But it also allows you to go back in at any time to view your performance graphically using the NPRQI dashboard and be able to compare that performance to your baseline performance and determine whether or not your strategy actually worked, meaning did it result in improvements over time. Next slide, please. So this is an example of the graphical views that any hospital will receive as a participant in the National PEDS Ready Quality Initiative. Looking at this graphical view, you can see different data points over time. This is tracked in this particular case on a quarterly basis. So quarter 1 of 2023, quarter 2 of 2023, quarter 3, quarter 4, and then moving into quarter 1 of 2024. And again, this is just an example. But what is graphed on this particular slide is the percent of pediatric patients with pain assessed in the emergency department. And you can see in quarter 1, they started at a lower value. In this case, approximately 40% of patients who had their pain assessment documented, measured and documented. And then moving into quarters 3, 4, and 5, you can see that there is a significant increase in the number of pediatric patients who had a pain score documented. Now, the difference between this graphical view and the tabular view is the tabular view is cumulative over time for the given time period that you're looking at, whereas this really allows you to hone in on how those improvement efforts are impacting care on a time basis. What you can further do, and if you click through the slides, is that you can see at what points you implemented the various change strategies that we just discussed and how it actually impacted performance. So in this case, as we described for Rite Aid, they started with staff education. It resulted in a bump in the percent of children who were assessed for pain during their ED encounter. Then they implemented a new policy with validated pediatric pain scoring tools. And then finally, they implemented an ER optimization alert to make sure that pain was assessed and documented in the electronic medical record. And you can see then how over time, with the implementation of these different strategies, they were able to impact change and increase the number of children who had pain assessed. Next slide, please. So in this, I think I'm going to turn actually over to Lisa. Sorry.
Yeah,
Thank you.
back to me. Thank you, Kate. So we are so excited to have you all, and we hope you all are really interested in getting registered for NPRQI. There was just a question that had popped up in the chat about the requirement for an agreement. So yes, when you begin to register for NPRQI, there is a participant organization agreement that needs to be submitted. We encourage folks to download that from the registration portal, get that routed as soon as possible. Most EDs are reporting that they can get that signed by their authorized signatory within 30 days or less. But we recognize that some sites do take a little bit longer than that. And then it probably takes us about a week or 2 weeks to turn that around and get it fully executed. So getting registered, sharing information about your particular facility, And then once you have that executed agreement, you'll get an onboarding email. You'll be able to access the data platform, begin entering your baseline data. We recommend when EDs are first starting out that they really aim for approximately 30 charts initially, just to get a good baseline data started. And then as you're entering in your data, you can go in and see your performance on your dashboards. Again, I'd mentioned that you can benchmark against similar pediatric patient volume hospitals as yourself, but also benchmark against the national performance as well. And as Kate had shown on the table view, you can actually identify where are the areas that we're doing really, really well. And then what are the areas that we really probably need to be prioritizing with quality improvement and identifying specific quality improvement strategies. And when Kate was talking about those different strategies, what's really nice about NPRQI too is that we also offer NPRQI office hours because we recognize for many sites who don't have a whole lot of experience with quality improvement, or maybe you're just now getting started, it can be kind of daunting to get started. And so we meet with sites twice a month where we do one-on-one technical assistance, coaching, really kind of get them started and helping to get their feet wet into the data portal and understanding the performance dashboards and helping them to identify some easy, quick wins that they may want to focus on. And next slide, Casey. Benefits for participating EDs. Obviously, being able to evaluate your pediatric emergency care is really important, especially using NPRQI's nationally vetted measures. Having the ability to monitor your ED's performance over time and benchmark against state and national performance is also a great benefit. I mean, for the first time, sites are actually being able to understand what does their performance look like. A lot of times when sites join NPRQI for the first time, they tell us that, oh, I had a sense of maybe how we would perform, but then when I started entering the data and I actually looked at my dashboards, there were things on there that I was not anticipating to see. So it really provides a tool for insights into the entire system of care for your pediatric patients. And then again, just being able to integrate quality improvement to meet that pediatric recognition criteria and any verification standards. And, again, just focusing on those key areas for quality improvement. And Casey, I think it goes back to you.
It's actually back to me, and I'll turn it
Oh,
back to
sorry.
Casey in a little bit. So what is a quality improvement collaborative? So I just want to reiterate a couple of things, which is, one, this whole process, this whole platform really walks you through how to engage in quality improvement. And there are some EDs that feel very well versed in quality improvement and can leverage NPRQI and work independently and engage with the platform to improve pediatric care. But for others, it might help to join what we call a quality improvement collaborative, or really a community for shared learning. And really wanted to share a little bit about what those are and also speak to a quality collaborative that's going to be coming up in January that you might be interested in joining, which is the EMSC and PRQI collaborative. But first, let's just talk a little bit about what we mean by a quality improvement collaborative and how it might help specifically your team or your hospital to engage in this work. So QI collaboratives are really structured, team-based shared learning networks where teams from a variety of different sites will come together and really test, measure, and work to sustain improvements in pediatric emergency care. It doesn't mean that everybody is working on the exact same thing, and certainly everyone is not working in the exact same environment, but it can really help to build momentum and camaraderie and support, as well as being able to have an opportunity to learn from other sites who are engaging in this work. Within our quality improvement collaboratives, it is indeed multidisciplinary. So every emergency department that's interested in engaging in this work is able to identify who would be most suited for being on their team. Oftentimes we see physicians and nurses working at least in dyads, if not having larger team groups with support from either ED and or hospital leadership who can help to make sure that the work continues. In addition, during these collaboratives, teams have an opportunity to share how they're doing, maybe not specific performance, but sharing whether or not their strategies worked and whether or not they're able to see improvements over time. And then in addition, sharing resources between sites. So here's an educational plan that we implemented and it worked really well. Others might share that so that you can take that back to your hospital or institution and try to use that as your intervention strategy. So it's really an opportunity to learn from each other. And during the course of the QI Collaborative, for those who have zero QI experience, it's really a way of receiving ongoing coaching, both from quality improvement experts as well as subject matter experts in the process, so you understand what it means to really make improvements in the care being provided to children over time. Next slide, please. So the quality improvement collaboratives that we lead within the EMS for Children program are really focused on specific gaps in pediatric readiness. And these are gaps that have been identified through the national assessments, most recently the national assessment in 2021, the upcoming assessment that many of you probably already started to hear about that's coming up in 2026. But during these collaboratives, it allows us to focus on core common deficiencies in pediatric readiness and offer coaching and that shared learning network to be able to address those gaps and overcome them. We support individuals that are serving more clearly in the role of a pediatric emergency care coordinator or PEC, and others who may not actually have that formal role or appointment. But what we do is we help teams to really review and track their progress over time using the NPRQI data. And we help with guiding them in choosing potentially the most effective strategies to implement and to be able to continue to benchmark and improve over time. And we really can see those measurable improvements of sites who have participated in these QI collaboratives. Next slide, please. So our quality improvement collaboratives leverage the Institute for Healthcare Improvement's Breakthrough Series model, which is a well-known, well-described structure for quality improvement collaboratives that essentially pulls in evidence-based content, national subject matter experts, and then helps to guide collaborative teams to implement strategies and improvements and then reassess how that impacted their performance over time. And these cycles of kind of reviewing performance, identifying opportunities, implementing a change, and then going back and reviewing performance again are known as Plan, Do, Study, Act cycles. So an example of this might be, as we saw in the case of Rite Aid, only 40% of children were having pain reassessed or documented within a 30-minute time period. So what did they do? They wanted to add a reminder in their triage area, a checklist to assess pain. And by doing that, it resulted in an increase to 65% of children who had pain assessed, and then they were able to expand that more broadly. So this is really the model of improvement that we leverage within our quality improvement collaboratives, and I think it provides a really nice structure, coaching, and support during the course of the collaborative period for teams who might be new to this whole process. So with that, I'm going to turn it back to Casey, who's going to talk about this upcoming Quality Improvement Collaborative.
Thank you, Kate and Lisa, for helping to lay the foundation of how pediatric quality improvement plays an important role in pediatric readiness and the ways in which a quality improvement collaborative can help support you in doing this work. As we've been alluding to all afternoon, we are excited to share this new opportunity to join the 2026 EMSC NPRQI Collaborative. This was formerly known as the PRQC, and we are set to launch a new cohort in January of 2026. This initiative is completely free and designed to support emergency departments in deepening their quality improvement work and strengthening pediatric readiness while collaborating with other EDs from across the nation. The EMSC NPRQI Collaborative supports EDs in transitioning from simply identifying gaps to making measurable improvements in pediatric readiness. As Kate mentioned, this is based on the IHI Breakthrough Series model. The collaborative guides EDs from identifying the gaps to implementing improvements through structured QI methods, expert coaching, and peer learning. Here's a little bit more about how it works. Your ED's team will work together to pick one of our 4 clinical areas of focus to work on improving. This ensures that your efforts are targeted and impactful. We then provide multiple touchpoints for engagement, with opportunities to learn from our subject matter experts, as well as your peers during collaborative sessions, fireside chats, and opportunities for one-on-one support during office hours. You'll use plan, do, study, act, or PDSA cycles to test ideas, refine them, and make improvements stick. While teams spend time implementing and assessing local improvement efforts within their ED, collaborative sessions serve as a forum for all participants to gather virtually and share their successes and challenges. By joining the EMSC NPRQI Collaborative, you'll have access to support and coaching to help guide you through the process. Because we believe collaboration is key, and you'll learn from your peers facing similar challenges. Having exposure to a variety of approaches, which helps you adopt proven strategies to your own environment. Participation in the collaborative can support your professional development while achieving other tangible outcomes, including improved patient and staff satisfaction, plus access to resources. This is your chance to make a real difference for the kids receiving care in your ED. So a little bit more about the National Pediatric Readiness Quality Initiative, a free self-paced quality improvement data platform, which is designed for emergency departments like yours. One of the biggest benefits is that it gives hospitals a clear framework for continuous quality improvement that is essential for improving pediatric readiness and making sure kids get the best possible care. This tool is really important for the collaborative as it allows EDs to track their progress while implementing quality improvement projects. Without NPRQI, it's hard to know if those changes you're making are actually moving the needle. So, the collaborative, is designed to give every ED the flexibility to focus on what matters most for their patients while providing support and resources. You'll choose one of our 4 clinical areas of focus, either pain assessment, abnormal vital sign reassessment, suicide assessment and management, or head trauma, which utilize one or more of NPRQI's quality measures. And you won't be doing it alone, as we provide that free coaching and NPRQI platform support, collaborative sessions, fireside chats, and the pediatric readiness, access to pediatric readiness and quality improvement experts. So this slide helps to highlight some real feedback from past participants during our previous cohort. Their experiences show the practical value and impact of being a part of this effort. Participants have shared that as a small hospital participating in the collaborative, they felt less alone when hearing from larger centers who were experiencing the same challenges, stating that they found it a motivating experience, while others found it beneficial to be able to adopt resources and best practices from those higher resourced EDs and apply them with their staff, providing them with the tools they wouldn't have had access to otherwise. Participants also shared that through the utilization of NPRQI, they had access to national benchmarking, which provided them with data to help drive their quality improvement and strengthen their ability to communicate results with leadership. So I would now like to introduce our guests so that you have an opportunity to hear directly from past collaborative participant and their experience in the collaborative. So today we're joined by Shelley, the Director of Emergency Services at Deaconess Union Hospital. She and our team were participants in the 2023 cohort, during which time they worked to implement quality improvement projects around pain assessment and abnormal vital sign reassessment. So thank you for joining, and I look forward to hearing from you today.
Hi, so like she said, my name's Shelly Alvey. I am the Emergency Room Department Director here at Deaconess Union County, Kentucky in Western Kentucky. We are a critical access hospital with a level 4 trauma center, and 30% of our clientele are pediatric patients. So whenever we got looking into our collaborative, sorry, my words aren't coming out today. We really had to revamp. I came into this role in the middle of already being involved with this. So I had to bring in a whole new team with us, and we were all very um, unknowing what we were going to get into. And all of the one-on-ones, the workshops, the fireside chats were very, very beneficial for us to be able to get our program up and running. Like was mentioned, we did focus on vital signs and pain. Those were our two areas that we lagged the most. It showed us where we needed to focus on. With pain, the biggest factor was that we needed to use appropriate pain scales. We didn't need to be using a verbal pain scale on a 1-year-old and things like that. So we now have education pushed out to the department. We have these scales posted in our emergency department. Our patients are seeing these signs. They're being able to verbalize which one they would prefer to use if we ask one route. And sometimes the parents will say, I think they'll might do better with this scale. And as long as it's age appropriate, we are very on board with that. Nursing staff is also doing a great job at charting those. It is integrated into our Epic charting system, and we've seen fantastic increases with our pain documentation and reassessment. Same with vitals. We had to push a lot of education out as to what normal vitals were, abnormal vitals were for each age group, when to reassess those, how to correlate that with their ESI that they were. We also went and completely revamped our ESI algorithm because with pediatrics, there might be a need to increase that ESI based on vitals that isn't quite the same as with an adult patient. So this was still new information that we were learning. And with all of the support from the collaborative, we have made fantastic growth. Our numbers are exceedingly well. I believe the last time that we checked, our vital sign assessment, pain assessment, were in the 90s with pain with vital reassessment in the low 90s, which is fantastic considering where we were when we first started this collaboration. It's also showed us that we had room to improve with our GCS. So we made new policies and protocols for that and have seen 40% growth in trend upwards for our GCS assessment and reassessment of pediatric patients. Just to ensure that they do have a more well overall assessment. Our pediatric team that we have here consists of myself, our champion coordinator, and our quality chairperson. She also doubles up as our educator because we are a small hospital with only 8 full-time staff and 2 part-time. So we have to wear a couple of different hats with this, which made it very beneficial to have all the support from the PRQI. They have done fantastic work. We're a very small fish in a large health system. And we have developed a pediatric specific clinical tool guideline for sepsis to help navigate providers on when they need to be ordering what orders, when they need to be initiating and bumping up into the next level. They wrote a oral rehydration policy and protocol that got implemented out throughout the system, including our hospitals with pediatric units that are in our health system. And currently we're working on improving our oral rehydration NPO challenge guidelines. So that's more so what we will be focusing on when we move forward. But have seen fantastic growth, and we're very proud of how well not only we could better ourselves, but our entire health system. We're very much looking forward to the fact that here soon we should be having our survey to earn our actual pediatric readiness certification. And none of this would have been possible if we hadn't had all of the support and materials and education that was provided to us through our national PRQI.
Thank you so much, Shelley, for sharing a bit about your experience and the ways that your work ended up impacting your health system. That's great to hear. And the efforts you're making to become pediatric ready recognized within your state. So we appreciate your involvement, and we look forward to seeing you and your team in our next adventure starting in January. Sounds like you've already started some work on our new bundle related to head trauma, so that's exciting, and we look forward to hearing you share your experiences and your work with those future participants. So thank you for
Thank you.
sharing. All right, so now that you've heard a bit about the EMSC NPRQI Collaborative, and you might be thinking, wow, that sounds great. I think I want to be a part of it. This next section is for you, and we'll walk through the steps to go ahead and get started. So again, starting next January, the collaborative will launch, and it'll be structured in 4 phases. We'll guide teams from orientation to lasting improvement, building upon each stage, ensuring that it's achievable and sustainable. So we will get started with our teams gaining access to the NPRQI platform, where you will be able to begin reviewing charts and entering data, attending fireside chats on your selected area of focus. This is also where you will begin reviewing our intervention bundles to help support you in your quality improvement activities. You will then complete the 2026 NPRP assessment and attend collaborative sessions and begin planning for your quality improvement project. During phase 3, teams will begin implementing those PDSA cycles with ongoing coaching and support. Additional data entry will continue through this phase so you can monitor your performance and identify changes that are resulting in improvement. So finally, we focus on sustaining your gains and planning for long-term success, reviewing opportunities to stay connected and continue learning. So to get started, you can begin by engaging your ED leadership and staff. We have some promotional materials to help you get your team excited about this opportunity to improve pediatric readiness. And if you're new to NPRQI, you'll first register for the platform and then share with us that you're interested in participating in the collaborative. You can join anytime between now and January of 2026. If you already have an NPRQI account, you can email me at collaboratives@emscimprovement.center to enroll, and we'll put that in the chat in a minute. And once you're signed up, you can begin assembling your project team, making sure to involve your ED's PEC. Like to think that they'll be a key champion to this work. Also include members who represent different roles within your ED: nurses, physicians, administrative staff, child life, quality improvement specialists, or health informaticists, just to name a few. You can get started today utilizing the EMSC NPRQI Collaborative Flyer to spread the word and sign up with NPRQI and start building your team. And remember, we're here to provide guidance and help make this a successful experience for you and your ED. So if you need a little extra support or guidance through this process, please reach out. We're also happy to schedule one-on-one meetings with you and your team to help explain this process a little bit more. So thank you all again so much for your time and attention today. We truly hope you'll be joining us next January for the EMSC NPRQI Collaborative. We do have some time today to answer any questions. Again, we're also available to schedule those one-on-one calls with you and your team if that would be of interest. I think Kate and Lisa have been answering some questions in the chat as we've been going, but if you do have any additional questions, feel free to put those in the Q&A feature.
Casey, I'd just like to make one comment. There was a question about guidelines. So I just want to clarify the difference between NPRQI and clinical guidelines or algorithms or policies. So within the EMS for Children Innovation and Improvement Center, which is inclusive of NPRQI, but much broader, that center, there's a website, which we've shared in the chat, emscimprovement.center. And there you can find a large number of resources, which include something known as the Pediatric Education and Advocacy Kits, also termed PEAKs. And these provide clinical guidance algorithms that are derived from evidence-based resources, evidence from the literature and published literature and guidelines that exist. That's where you can go if you're looking strictly for clinical guidelines or algorithms that you might choose to adopt. They're recommendations. They're not necessarily intended to be the national standard that everyone must follow, but they at least provide evidence-based guidance. NPRQI is a step past that, where we have worked with national stakeholders, national organizations to identify the steps in evidence-based practice and then prioritize those steps and whittle them down to the most critical foundational elements of care. And those are what we call our quality measures, or the measures that are embedded in NPRQI. And so one of the questions that came up was related to, measures that we might use, for example, for head trauma. So in this case, we're looking at things like assessment of mental status, reassessment of mental status in head trauma, alignment with national guidelines for imaging for reduced dose radiation. So hopefully that explains a little bit about the difference between clinical practice guidelines and NPRQI, but by virtue of participating in NPRQI, you are able to see in real time how you're performing in alignment with evidence-based practices.
Right. A couple other questions about access to the links we've shared today and today's recording. We'll make sure you all have access to that following today's session. I'm also pretty sure Lisa's put in the chat by now or will soon the link to go ahead and get registered for NPRQI. If you're ready to get started on that process, or you can use that QR code on the screen.
Yes, I've placed that in the chat, Casey. I've also placed the NPRQI clinical quality measures. There was also a question about meeting with ED leadership. We do have some promotional materials that I've placed in the chat as well, specifically for ED leadership and C-suite. So it's really kind of like ready-made talking points that you can just pop into an email and send off, along as with a flyer for the collaborative.
And it sounds like some people are having trouble accessing
Okay.
some of these through here. So
Okay.
we will make sure we get those out maybe via email. Casey, is that what you said? We can email registrants.
We'll follow up with the recording of today's session, the presentation, and the resources that we've shared as well. I don't know, Lisa, if you shared the link also to just the NPRQI resources page. If you're unable to download the files, you can access them there.
Yeah.
What other questions do you all have? Be a good question. And how can I convince my organization that we need to do this in addition to the facility PEDS gap analysis?
I think the flyers that we have will help you there. We specifically created these promotional packages for C-suite and ED leadership, but this is really about decreasing risk. It's about ensuring that we're meeting the needs of all children who come to the ED. And I think the value proposition around pediatric readiness is well outlined in the literature and even in public media outlets like, New York Times, Wall Street Journal, etc. So with endorsement from national professional societies and now integration of pediatric readiness requirements, not only in verification standards like the American College of Surgeons and the new ACEP ED accreditation program, but also becoming more and more prevalent even within state-based rules and regulations. As we've just seen in Texas, for example, we just pushed out some new Texas trauma rules that integrate many of these elements embedded within NPRQI and the requirement to engage in pediatric quality improvement. So I think there's a lot there that can be shared to make the argument and to make the case about saving lives and decreasing risk. And if the materials that we have aren't enough, please reach back out to us, and we are happy to assist you in whatever way we can to make that argument.
Another question come in. What if we don't have all the people you described in the ED or the hospital? We don't have child life, care management, etc. in our ED or the hospital.
I would say most of our participating sites don't. Many of our participants in our quality collaboratives are teams of one. Ideally, it's teams of two, usually at least a physician and a nurse, but you don't have to be a big team to do this work. You can self-pace, you don't have to, it doesn't have to be a heavy lift. It's really entirely up to you and your team about how much time and energy and human resources you have to dedicate to this. So, it does not have to be a huge multidisciplinary team. It's just that we do encourage, to the extent possible, having both a physician and a nurse engaged in the work.
Thank you for your question, Susan.
And Casey, there was another question about training being offered for the new platform. So for folks that are current participants, they are in the process of submitting their updated POA, which is the one that I posted in the chat. We already have many folks who have already submitted that, so they're going to be ready to go. When we launch the system in January, we will be beginning training sessions. We also host office hours twice a month, so sites will be able to sign up for office hours for one-on-one support with navigating the data portal and the dashboards.
Additionally, we'll have the NPRQI team on our collaborative sessions to offer support and address questions as they come up as well. We have a question in the chat looking for recommendations for guidance on respiratory therapy.
So we are actually in the process, so within the EMSC Innovation and Improvement Center, we are in the process of developing a PEAK, Pediatric Education and Advocacy Kit focused on asthma management. And I don't know specifically if you're, I imagine you're talking about all respiratory conditions, not just asthma, but perhaps croup, pneumonia, management of any respiratory distress. But that will at least serve as a starting point. This collaborative is not specifically focused on respiratory conditions, but within NPRQI, you can certainly choose to do that and focus on children who present with respiratory distress. But be on the lookout for our asthma peak that will be coming out in the next few months.
No, we are over time. We appreciate you all joining today. If you have any additional questions, please reach out and we can help address those. And we look forward to seeing you next January.
Thank you all for joining.
Thank you for joining, Shelley.